Welcome to part 1 of our pneumonia review for Step 2. In this video, we will master the classification of pneumonia, the key pathogens, how to diagnose it, and how to decide between outpatient and inpatient management. Part 2 will cover treatment and special types like aspiration pneumonia. Let's get started. Pneumonia is classified by where it was acquired. Community-acquired pneumonia, or CAP, is acquired outside a healthcare facility. Hospital-acquired pneumonia, or HAP, develops more than 48 hours after admission with no evidence of disease on arrival. Ventilator-associated pneumonia, or VAP, occurs in patients on mechanical ventilation, typically in the ICU. Clinically, pneumonia also presents in two patterns. Typical pneumonia has classic symptoms with abnormal lung exam findings. Atypical pneumonia has a more indolent course, often with unremarkable auscultation. The Step 2 Pleural. The 48-hour rule is critical. Pneumonia developing within 48 hours of admission is still classified as CAP, not HAP. Streptococcus pneumoniae is by far the most common cause of CAP. It is also the #1 pathogen in nursing home residents and in IV drug users. Haemophilus influenzae is common in COPD patients and smokers. Moraxella catarrhalis also affects COPD patients. Klebsiella pneumoniae is classic in alcoholics and aspiration pneumonia. Look for current jelly sputum. Staphylococcus aureus is the classic post-influenza superinfection, often producing cavitary lesions. The Step 2 Pleural. Strep pneumo is the default answer for most CAP questions unless there is a specific clue like alcoholism, post-flu state, COPD, or bird exposure. For atypical pathogens, use the mnemonic. Legions of clams mind their P's and Q's. L is Legionella pneumophila, associated with contaminated water sources. Hyponatremia, GI symptoms, and elevated LFTs. C is Chlamydia pneumoniae, common in young adults with mild disease. M is Mycoplasma pneumoniae, the most common ambulatory pathogen, especially in teens and young adults, classically associated with cold agglutinins. P is psittacosis from Chlamydia psittaci, exposure to parrots or birds. Q is Q fever from Coxiella burnetii, exposure to farm animals, especially parturient livestock. The Pleural. Atypicals cause walking pneumonia, mild symptoms, dry cough, unremarkable exam, but an abnormal interstitial pattern on chest X-ray. First-line treatment is a macrolide or doxycycline. Hospital and ventilator-associated pneumonia are dominated by gram-negative organisms. Pseudomonas aeruginosa is the classic VAP pathogen. Other gram-negatives include Enterobacteriaceae like E. coli and Klebsiella, as well as Acinetobacter. On the gram-positive side, Staphylococcus aureus, especially MRSA, and strep pneumoniae are common. Risk factors for multidrug-resistant pathogens include IV antibiotics within the past 90 days, septic shock at the time of VAP, preceding ARDS, or acute renal replacement therapy. The Step 2 Pleural. HAP and VAP empiric therapy must cover both Pseudomonas and MRSA when MDR risk factors are present. Pathogens vary significantly by age and host factors. Newborns, GBS, Streptococcus agalactiae, E. coli, Listeria. Children ages 4 weeks to 18. RSV, Strep pneumoniae, Mycoplasma. Chlamydia pneumoniae. Young adults, Mycoplasma, Chlamydia, Strep pneumo, influenza. Adults 40 to 65, Strep pneumo, H. influenzae, Mycoplasma, anaerobes. Elderly, Strep pneumo, H. influenzae, gram-negatives, influenza. Immunocompromised patients, especially those with HIV, are classic for Pneumocystis jirovecii pneumonia, as well as CMV and fungi like Aspergillus or Histoplasma. Alcoholics and aspiration pneumonia, Klebsiella and anaerobes. Post-influenza, Staph aureus. Cystic fibrosis, Pseudomonas, Staph aureus, and Burkholderia chapucha. The most common route of infection is microaspiration of oropharyngeal secretions. Lobar pneumonia, classically caused by strep pneumoniae, evolves through 4 pathologic stages. Days 1 to 2. Congestion, red-purple parenchyma with serous exudate and rare inflammatory cells. Days 3 to 4. Red hepatization, red-brown, firm tissue with a liver-like consistency, filled with fibrin, red blood cells, and neutrophils. Days 5 to 7. Gray hepatization. The tissue becomes uniformly gray as red blood cells degrade and suppurative exudate accumulates. Day 8 and beyond. Resolution. Gradual reaeration with enzymatic fibrinolysis and macrophage clearance. Clinically, pneumonia also presents in 3 anatomic patterns: lobar consolidation, strep pneumoniae, bronchopneumonia, staph aureus, Klebsiella, and interstitial pneumonia, mycoplasma, viruses. Let's compare typical and atypical pneumonia side by side. Onset. Typical is sudden and acute. Atypical is indolent and gradual. Fever. Typical is high with chills. Atypical is low grade. Cough. Typical is productive with purulent yellow-green sputum. Atypical is non-productive and dry. Auscultation. Typical shows crackles, bronchial breath sounds, and dullness on percussion. Atypical is often unremarkable. Chest X-ray. Typical shows lobar consolidation or bronchopneumonia. Atypical shows diffuse reticular or interstitial pattern. The key clinical pearl for atypical pneumonia. The chest X-ray looks worse than the physical exam. That's why it's called walking pneumonia. First line treatment. Typical pneumonia gets amoxicillin or a beta-lactam. Atypical pneumonia gets a macrolide or doxycycline. Routine labs in pneumonia typically show leukocytosis with a neutrophilic predominance, elevated CRP, elevated ESR, and elevated procalcitonin, a specific marker for bacterial infection that can also guide when to discontinue antibiotics. For severe CAP, obtain blood cultures, 2 sets, sputum culture and gram stain, influenza and COVID-19 testing, and both pneumococcal and Legionella urinary antigens. For non-severe CAP, selective testing is appropriate. Test for influenza and COVID during high transmission periods, and obtain sputum culture only for patients with recent IV antibiotic use or structural lung disease. The Step 2 Pearl. Cold agglutinins with hemolytic anemia points to mycoplasma. Hyponatremia, diarrhea, and elevated LFTs point to Legionella. Chest X-ray with PA and lateral views is the first-line imaging study. A new pulmonary infiltrate in a patient with classic symptoms confirms the diagnosis of pneumonia. 3 patterns to recognize. Lobar pneumonia shows lobar opacification with air bronchograms, classically caused by strep pneumo. Bronchopneumonia shows poorly defined patchy infiltrates, classically caused by staph aureus or Klebsiella. Interstitial pneumonia shows diffuse reticular opacity, classically caused by mycoplasma or viruses. Chest CT is reserved for inconclusive chest X-rays. Recurrent pneumonia, where you may need bronchoscopy to rule out an obstructing mass, or poor treatment response. The Step 2 Pearl. Cavitary lesions suggest staph aureus, post-flu, tuberculosis, anaerobes, or Klebsiella. But remember, pathogens cannot be definitively identified from imaging alone. The CURB-65 score helps decide between outpatient and inpatient management. Each criterion is worth 1 point. C for confusion, U for BUN greater than 19 milligrams per deciliter, R for respiratory rate of 30 or higher, B for low blood pressure, systolic at or below 90, or diastolic at or below 60, and 65 for age 65 or older. Score of 0 or 1. Outpatient management is appropriate. Score of 2. Consider hospitalization. Score of 3 or higher. Hospitalize. And consider ICU admission if the score is 4 or 5. The Step 2 Pearl. CURB-65 predicts mortality risk, not the need for ICU admission. ICU admission should be based on clinical judgment, things like septic shock or need for mechanical ventilation. Let's summarize Part 1. For classification, CAP is outside the hospital. HAP is more than 48 hours after admission, and VAP is on mechanical ventilation. For key pathogens, strep pneumoniae is the #1 CAP cause, H. influenzae in COPD, Klebsiella in alcoholics, staph aureus post-flu, and Pseudomonas plus MRSA in HAP and VAP. The atypical mnemonic is LCMPQ, Legionella, Chlamydia, Mycoplasma, Psittacosis, and Q fever. For diagnosis, a chest X-ray showing a new infiltrate plus classic symptoms confirms pneumonia. In severe CAP, always send blood cultures, sputum, and urinary antigens for strep pneumo and Legionella. For disposition, use CURB 65, 0 to 1 outpatient, 2 or more hospitalized. Finally, the classic Step 2 traps. Cavitary lesions mean Staph aureus, anaerobes, or TB. Current jelly sputum is Klebsiella. Hyponatremia with GI symptoms is Legionella. And CURB 65 predicts mortality, not ICU need. In Part 2, we will cover empiric antibiotic treatment for CAP, HAP, and VAP, plus aspiration pneumonia, complications, and prevention. See you in Part 2.